Good morning. It's a real pleasure to be here. Thank you for getting up so early and being here. I'm going to dive right in. For those of you who know me, the probability that I get the memo is generally not that high. So I have too many slides. I was thinking that this was longer, but I will go through them quickly, and I can always be cut off. So the title has shifted slightly, How to Do More with Less. And I wanted to share some thoughts about implementation science in this space, given where we are at this moment. So, a brief outline. I think we all recognize the need for implementation science. I'm going to say that we're at a critical juncture. Turns out there's a theory for this, critical juncture theory. I'm going to say something about that, and then I'm going to list the top 5, 10 strategies for shaping the future of the HIV response using implementation science that is responsive to this critical juncture, and make the case that Asia has a distinct role to play. So this is going to be quick. I often use this to illustrate the need for implementation science, okay? So in 1982, the definitive randomized trial was done that showed that beta blockers reduce mortality as a single endpoint of death after a myocardial infarction. Get a heart attack, need beta blockers, saves lives. In 1997, this is in the United States, but the situation around the world is similar, if not sort of more severe. Only a third, this is 15 years later, only a third of patients who had a heart attack were discharged with a beta blocker. And it wasn't until 2007 when a national sort of quality improvement assessment had been done that demonstrated that basically everybody who had a heart attack was discharged with a beta blocker. So this took 25 years. This is not a scientific analysis, but if you apply the effect size of the study to the number of people in the United States who have a heart attack in each of these years, and you imagine instant implementation, over the course of that 25 years, about 500,000 lives would have saved. The actual rate of implementation meant that about 180,000 lives were saved. The lost opportunity was about 60% of the total. So our inability or our delays in implementing evidence-based interventions have consequences for the health of people and populations. So we would like to think that this is an isolated case, but in truth, it's not. If you look across disease conditions, hypertension, diabetes, HIV, and other things, there are many, many conditions in which implementation is incomplete, slow, or unsustained. And I think recently there's been some research that's been done that showed globally about 10% of people who could benefit from aspirin primary prophylaxis are receiving it. So this is the situation we're in. Implementation science is a field that grew up and was motivated to address this problem. I won't go into the details here, but it is really only in some ways like a decade or 15 years old. Most of the major conferences, the journals, the concepts have all emerged in a relatively short period of time. Sorry, 15, 20, something in that range, 20 years. This is a changing, moving target. NIH investments in implementation science in the United States have also grown quickly. This 1.4 billion figure is a little bit overstated because the NIH counts any project that has any implementation science, it counts all the dollar amount towards it, but for sure it's grown. And obviously things at the NIH are uncertain and in some kind of turmoil, so we don't know what the future holds, but this is the situation up until at least a couple of years ago. So I think at the end of the day, the implementation science movement extends the evidence-based medicine movement, right? And so when I was a medical student, this idea that practice needed to be scientifically based had sort of become the dominant paradigm. Implementation science says, no matter how good your evidence is, if it's not used, it's not doing its job and it's worthless. So it builds on evidence-based medicine, but it is also a critique of it. That's I think, what we hope to achieve with this field. Okay, I'm going to talk a little bit about some of the central perspectives. Zhang Ye just gave an outstanding talk about just these things, so I won't belabor them, but sort of the critical commitments are that implementation has to be examined with a scientific lens. In clinical diagnosis, in clinical medicine, we have science about how to diagnose problems, how to understand problems, and then how to treat them. In implementation science, likewise, we need a scientifically based understanding of the implementation problem, a implementation diagnosis and scientifically based treatments for those problems. Many of you know these frameworks. They're a beginning point for understanding and making these diagnoses. They help you think through the implementation problem specifically, but I won't spend much time talking about them because I want to get to some of our sort of top 8 things for the moment. These are strategies. Zhang Ye just talked about them. Okay, so where are we at this moment in the HIV response? Well, this is, the Asia-Pacific region has not sort of been as heavily or overwhelmingly sort of donor-supported in its HIV response in a way that Africa is. But as you know, there's been many disruptions. Many people in this room have been affected by them. And they're happening at a large scale. There are many modeling studies projecting the potential impacts of this. This is just one of them. There's probably dozen or 2 dozen at this point. But it's, no matter how you slice and dice it, we're at a moment of crisis. So in political economy, there's something called critical juncture theory. And critical juncture theory says a few things. Number one, that large-scale change happens at particular moments. So a lot of times there's a status quo. Institutions are firmly set. You go along and you do stuff. And then there's a moment of disruption. And at that moment, there's a few characteristics. So number one, there are moments in history are branching points where multiple paths with long-term consequences are present, okay? So when there is this shock, there's institutional disarray and breakdown. And during times of institutional disarray, agents, so individuals who work in those systems, may have an outsized ability to influence the system and the institutions going into the future. And then once things stabilize again, many of the actions that were taken will become sort of more set and have long-term consequences. So for science, this is an opportunity for us to think about where we want to come out on the other end of this critical juncture, because if this is sort of a figure that's been taken, you end up with a new status quo that could be very good, but you also could end up with a new status quo that's, the same or worse if it's not managed or acted on properly. So what are the things that we can do to have implementation science and the HIV response land where we want? Okay, so I don't know what to call this. This is an arbitrary figure that I came up with based on nothing scientific except my own opinion, which is not scientific. But on the x-axis is the price of the research study. On the y-axis is how good it is, okay? And I'm going to not justify the internal black box algorithm that tells you how good it is. But in my opinion, these are studies, the higher up on the y-axis, the better the study was, okay? For some reason, impact, insight, creativity, something. So if we draw a little bit of a figure here, and we ask ourselves, what are the characteristics of the studies that are in the top left and in the bottom right? Sorry, I may need to remove some of the... But at any rate, what makes a study like inexpensive and good? Okay, and then what makes a study expensive and not that useful? And I think by reflecting on this a little bit and trying to draw out a few of these lessons, we might ask ourselves, what can we do now with, what can we do with less? And then where do we want science to land in the future so it continues to be more impactful and more efficient and less expensive? So the following 8, so I picked 8 because 10 was too many, and then 8 is a lucky number. Ba, fa. just to point out a few things, and I think these are worth just noting and perhaps percolating on. Okay, so number 8. I'll do a countdown from 8 to 1. Very fast, 1 a minute. So number 1, randomized trials can be cheap. We hear a lot about randomized trials that cost 10, 20, 30, 40, $50 million. Thomas O'Denny did a randomized trial of 1,200 people for follow-up after VMMC using SMS, randomized trial, for between $5,000 and $10,000. And this study was published in PLOS One. It had some interesting insights in it, which basically demonstrated, this is some time ago, that text messages help people follow up, okay? Simple, randomized trial, effect size, 5-7%, number needed to treat about sort of between 1 and 20 and 1 and 10. But the bottom line is that it cost somewhere in the $5,000 to $10,000 range. So the secret sauce here was leveraging technology and having a modest interim outcome, which was follow-up, and being attuned to the context. So I think when we say randomized trial in the future, we don't mean that it has to be expensive. Okay, number 7, leverage social mechanisms. So in our panel in the last hour, in fact, one of our colleagues from the Philippines asked a very insightful question about social relationships and how they influence what we know and what we do. So this is a study that was published in The Lancet by a group out of Cornell, which leveraged the working with religious leaders during a VMMC HIV prevention campaign in Tanzania. So they randomized communities to working with the religious leaders to promote the voluntary adult male circumcision versus not. And it's a cluster randomized trial, 150,000 people, statistically significant, large effect sizes and outcome. What's one of the most interesting things about this study? When you go and look at the funding, it's a K-23 and a K-24. So it's not a huge amount of money, but by touching the right levers in the social system, because they were insightful and smart about how to do that, it had large effects. So again, small amount of money, big effect. Even though I've just talked about trials, there is also, I think, an opportunity to think about rigor with relevance in natural experiments. So a lot of times, especially in HIV, we do a lot of randomized trials, and we think that randomized trials are the way to go. But in fact, there are many situations in the world where the universe presents us with as if randomized situations, and if we're observant and keen, we can find those situations and exploit them for insights, for scientifically based insights. Very few people do this as well as Jacob Bohr, who's based out of Boston University. So this is an example. He uses a regression discontinuity to look at the effect of treatment offer at a time when treatment initiation was restricted to 350. So remember, a decade or more ago, 350, above 350, no treatment, under 350, HIV treatment. This is in Africa, in South Africa specifically. So if you think about it, the people who fall immediately above 350 and immediately under 350 are not different. If you come to clinic today and you're 360 and I'm 340, there's no difference between us. But what happens to us is basically as if randomized, right? And by using mechanisms like this, he's able to understand the effects of treatment offer on retention, on clinical outcomes, and on a range of things. I have 6 minutes apparently, and 6 more to go. So, okay, number 5, and I'll make this quick again. I think we should trust what people say. So we don't have to have a viral load as an outcome in every study. We can ask people what they believe, and we can use that information to guide our practice in a scientific way. I'm going to, I won't get into the details. Both of these are studies that our group did about healthcare workers being nice and the effects of healthcare workers being nice. We did a choice experiment on this to show that healthcare workers being nice was worth essentially 40 kilometers of travel distance to patients or 10 hours of waiting time. And that study cost like $10,000. Then we did a huge cluster randomized trial. And that cluster randomized trial cost $4 million. So we have to ask ourselves, I'm not saying that the cluster randomized trial wasn't worth doing. I think it was, but it is an open question. How much additional bang did we get for our buck by getting a retention outcome, by getting a viral load outcome, versus just believing what people have to say? So that's something for us to consider. Number 4. I think it's worth, in implementation science, reimagining impact. And this is maybe a little bit esoteric, so I won't belabor it. But sometimes we think that we have to do a study to change practice for it to be impactful. But in fact, much of research changes the world by changing the general way that we think about things, by changing paradigms. And I think that we shouldn't sell ourselves short when designing research if we don't have a practice-oriented outcome that we have in mind. Carol Weiss wrote a lot about this. I have an example, but I think that's something for us to think a little bit about. Okay. 8 was probably too many, but I couldn't have gone with 4. That would be a problem here. But I think it's worth also investing more in thinking in research. I think we have, at least in the NIH model, this tendency to overpromise, to overmeasure, and not to make the most of what we've done. Because we don't have time to think about it. And I think investments in people and time and investments through mechanisms like K's, but other maybe even more expanded mechanisms like they have in Europe that just supports an investigator will help us make the most out of our research. That includes thinking about maybe what the questions are and theorizing a little. Okay, last 2. From add-on to infrastructure. So can we bring implementation science into implementation? I think in many cases we can. In the United States, people talk about program science, right? This is a big thing. A week ago, I was in Nanjing, and my colleagues presented some work there, and it's already being done. The CDC in Jiangsu is doing randomized trials of group-based mental health support for people living with HIV. It's done, funded, conceived of, and executed within programming. And maybe that is a route to true sustainability of implementation research. Okay, last one. Appreciate and build on assets. So I think we often think in science that we need to identify a problem. But in fact, maybe the most efficient and impactful way to solve problems is to identify an asset and to appreciate it. No one does this better than Joe Tucker. It's a beautiful thing to see. And I think that we collectively as a scientific community need to take that kind of an orientation. And by doing so, maybe we can do more with less. Okay. That is it. Those are my top 8. I'm going to end with this sort of semi-pseudo-Chinese etymology. So I was actually looking up the, how many people say in Chinese, the word for crisis contains the word for opportunity, right? Like 危险. If you look at the etymology, that's not actually totally true, but an old version. This is one of the old versions of Wei, which is sort of danger, and it's you can see it's a guy. It's a sort of a person like this, but with one very long leg on top of a mountain. It's on top of a mountain, and it gives you the sense that it's dangerous because the person is on the precipice, and in fact, one leg is kind of going over the edge. So this is where we are in the HIV response. We are on a precipice. We're at a critical juncture. We need to find our way down the mountain, and the paths that we choose will determine whether or not we get down the mountain safely or not. And I think that there is an opportunity to think about that. There's an opportunity to make the right choices now, and for us to collectively end up in a better place than maybe where we started, and maybe even better than we had imagined. So with that, let me stop and hand it back over to the chair. And thank you very much for your attention and interest.